morning, ma'am. Thank you for this opportunity. Is my screen visible and am I audible?
Yes, please go ahead.
So now we know what is CVI and what was MDVI and what is the importance of these children. So I would re-emphasize that CVI is a true visual impairment. Also that these children are our special children. So parents come to us with the complaints that the child does not have a good eye contact, or they're unable to grab objects to hold their toys. Apart from this, they would come with a complaint of cataract or white reflex, squinting or shaking of eyeballs. So what are the known ocular associations is reduced visual acuity, or they would have crowding phenomenon. They would have reduced contrast or the optokinetic nystagmus, altered fixation, altered perceptual abnormalities, abnormal smooth pursuit and saccadic movements, and strabismus, nystagmus, and altered stereopsis. So what literature says in this paper by Jacobson is that the most common visual field, most common ocular association was reduced visual acuity, and the least common what they found was reduced visual field. Unlike this, but we find in our clinical scenario in a day-to-day practice that most of them, these children would definitely have a field defect also, as mentioned previously. Now we go on to assessment. So to assess these children, since these are special children, as I said, what we need is that we need a room which should be clutter-free, which should not be very compact with toys, and the examiner should wear a cloth or an apron which is dark or a uniform shade. This would mask the patterned appearance, and not very bright eyes or not very toys which would make a squeaking sound. So we would prefer to use targets which would have facies, and these facies would have discrete features like eyes, mouth, nose, because the child starts appreciating or gazing at the mother's face in the beginning and knowing these features. So by fixation, we would want to know the visual sphere, at what sphere the child starts working or prefers to look at objects. Then we can go ahead with the visual acuity. We know these are the standard tools which are available. In children, we would use paddles like Leah gratings. This video would show how the Leah paddles are used. These are based on preferential looking test, where there's a controlled diffuse background paddle and alternate black and white striped, where the thickness decreases gradually. And as we try to do this test, we would see that first we should sit at the parallel level of the child, and both the paddles are held such that, both the paddles are held such that the control paddle is on the first and the striped one is hidden behind it, and then they are swapped across and look towards which side the child prefers. It can be done both uniocularly as well as binocularly. The other modality which we routinely use is TAC, which is again Teller's acuity card based on preferential looking. The examiner here is trying to appreciate the response of the child through the peephole, whether it is preferring to look the stripe patterns or the diffuse background. Again, this can be done both monocularly or binocularly. Other cards which uses vanishing optotypes for a little older children or for milder CVI are CAT cards. Allen's or Leah symbol can also be used, as we know. They can do Leah matching at the beginning. Another important tool is optokinetic drum, which when rotates would elicit a fast following movement, a slow pursuit movement, and a refixation movement, the saccadic movement. The response would be in the form of nystagmus. Once this optokinetic nystagmus or response is elicited, it gives us the intactness of visual pathway. In older children, Sling, Snellen chart or E-chart can be used. However, one would prefer to give them single optotypes to get a better response, since they would have crowding phenomenon. Now, VEP is another objective tool to assess visual acuity in these children. It would give us the intactness of the visual pathway. More so, the flash VEP would just give the response, and a sweep VEP is preferable because this gives us with a rapid sweep within a 10 seconds duration, where these children would have a smaller attention span. So this is how the levels of visual acuity in CVI children has been quantified in a paper, right from light perception to occasional fixation to level 5, where we see the visual acuity is between 2050 to 2200, and level 6 is normal sensory examination. Then when we start doing refraction, we need to do one static retinoscopy followed by cycloplegic retinoscopy. In cycloplegic retinoscopy, one should remember that the cycloplegic agent used here is not cyclopentolate, rather HEIDI and atropine, which does not have any neurological side effects. Near retinoscopy is a must in these children because they would also have accommodation problems. So what literature says regarding the refractive errors, in preterms, myopia and its association with ROP was more common. Children with PVL who have escaped severe ROP, hypermetropia was found to be more common, along with astigmatism. And children with CP also had hypermetropia, and accommodation insufficiency is seen in most of these children. So assessment of accommodation is done using a RAF ruler or by dynamic retinoscopy using monocular estimate method, where initially we ask the child to fix it on a near accommodative target, then look back at a distance and again at the near target, so that if there is any accommodation lag, we would know by the movement and then prescribe any hyperopic glasses or bifocals. So this was a paper from from our institute where we found that refractive error, the most common ones were simple myopic astigmatism and compound myopic astigmatism. Color vision assessment is also done in these children using Ishihara pseudoisochromatic test or the Farnsworth test. But more important is the contrast sensitivity, because we see most of them would have reduction in contrast sensitivity. And also because the daily facial expressions, day-to-day activity are typically of low contrast. So what we use is the Leah low contrast symbols or the Leah grating test. It has been seen that the HEIDI test has a positive correlation with the Pelly-Robson chart, and HEIDI test has with higher contrast with a darker background smiley, which is altered or swapped right from the dark one till the less one. We have to see if the child can attain till the level of 2.5% contrast. Field effects are more common, and this can be elicited right from the history, whether they are tripping over the floor or difficulty in walking downstairs. Most of them, as discussed, would have inferior field effects due to superior periventricular damage, would also have right homonymous hemianopia. Tests used depends upon the age, the degree of severity of CVI, whether Humphrey confrontation can be tried in older children, the leg raise test, puppet facies, and the Leah-Wand test. Here we see for children a 2-pencil confrontation test is done, and the other target is moved in all the quadrants, asking him to testing his fixation or the field effect till where his eyes can move. This is an illuminated target, which is called the Leah-Wand, which is brought superiorly, inferiorly, right gaze and left gaze to assess which field is affected. In this video, okay, so field effect, we would try to take a smaller target, which I can show with a board or some obstacle here, and move the target up or down and watch how this child is moving her eyes. Sometimes a child will move in all the directions except at one direction, where we know that this is the field which is affected. Apart from this, pursuit and saccades are also affected as discussed. And so one would have to move the head rather than moving only the eyes. So we would know that there is a head thrust to look at an object. In this video, we are trying to assess pursuit and saccades, giving him a target and seeing how the child is following the target which is given. Now coming on to strabismus, esotropia is most commonly noted. Exotropia is seen is constant and associated in severely affected patients. But the classical nature in these cases is the dyskinetic strabismus, and there is an angle variability, the shifting pattern, that at few visits we would see that there is exotropia which would have changed to esotropia in the subsequent visits. Assessment of strabismus is little similar to what we do routinely. However, in these children, most of the assessment is based on the corneal light reflex tests, the near cover test. We have to do repeated assessment before we decide on any surgical correction to attain a stability of deviation. Ocular examination is must, assessment of pupils, and anterior segment examination either using a portable slit lamp or even a distant direct ophthalmoscope when children will not be able to sit on the slit lamp, and for fundus examination to look out for disc pallor, any macular pathology or retinal pathology, previous laser scars. We have seen that in optic disc findings in early PVL are small hypoplastic discs, whereas in older children, they would have normal discs with large cups, which were initially known as pseudoglacomatous appearance. Now they are classically called as PVL discs. So to summarize, these are the neuroophthalmic associations of CVI. They would have gaze deviation. This is based on the level of damage, whether it is cortical or subcortical. They would have nystagmus, strabismus, and optic disc abnormality. So I would just like to conclude that, again, what Helen Keller has said, it is not just one examination, but it is the team effort, what we are trying to do, that alone we can do so little, but together we can do so much to bring in smiles in the parents of these children and make these children at least confident to face their peers. Thank you.